Good evening, everyone, and thank you all for coming out for what I hope will be a very interesting, enjoyable, and entertaining program on ankylosing spondylitis, axial spondyloarthropathy, whatever your persuasion is and what the naming of this entity should be. I'm Alan Grabowski. I'm here from Hospital for Special Surgery in New York, and with my colleague, Dr. Jörg Ehrman. We're going to be from Brigham and Women's in the great city of Boston. We're going to be talking about precision medicine and ankylosing spondylitis. But we're going to try in the course of this evening to give you an overview of this entity and why it is important for the non-rheumatologist to be familiar with its diagnosis, with its treatment, and most important, the impact that it will have on the quality of life of our patients with this and related conditions. So over the course of the last several minutes, you've seen all of our relative disclosures running on the screen, and you've gotten the housekeeping lecture from our pre-moderator. But I want to stress to you the learning objectives, and because part of what you're going to evaluate towards the end of the session is to what extent the learning objectives have been made. So first, we want you to recognize the key clinical features of ankylosing spondylitis, axial spondyloarthropathy, to aid in the timely diagnosis. Next, we want you to understand the classification criteria and the diagnostic tests, and as you'll hear, classification and diagnosis are not identical, but how you're going to incorporate them into your clinical practice to both support early detection of AS as well as the management of patients throughout the course of their disease, but more important for those in internal medicine, the management and monitoring of patients who are on the therapies that we rheumatologists put them on. And then we're going to be talking about the biologic therapies for AS and how they impact clinical practice. What will their effect be on comorbidities? What is the importance of being on them for when it is or when it isn't that you can vaccinate patients in your practice? So let's begin then with key objective number one, which is the key clinical features of ankylosing spondylitis to assist in making the timely diagnosis. And Jörg, why don't you take it from this point for a bit?
Yeah, so although we are going to focus on axial spondyloarthritis and ankylosing spondylitis tonight, it's important to put this into context. Ankylosing spondylitis is part of a family of diseases, the spondyloarthritis family. And in addition to ankylosing spondylitis, that includes psoriatic arthritis, reactive arthritis, IBD-associated arthritis, and more undifferentiated variants of disease. And what they have in common is that they have overlapping clinical features. So involvement of the axial skeleton, inflammatory back pain, arthritis in the SI joints is something that can be seen in all of these spondyloarthritis. Enthesitis and dactylitis are common features, and inflammation of the skin and in the intestine is something that is shared. And why are there these overlapping features? The reason for this is that these diseases share common disease pathways, and there's also underlying genetics that is common. And that is reflected in shared family history. So if you have a first-degree relative with one of these spondyloarthritis families, then you are at an increased risk to develop any of the other spondyloarthritis diseases. And that is not the same with rheumatoid arthritis, for instance. So this genetically is a group of diseases. So on this cartoon here, you see that we have nicely differentiate between axial spondyloarthritis and peripheral spondyloarthritis. AS is the prototypic axial disease, and this is what we're going to focus on today. But in the real world, it's not that clear cut. So patients may present with axial features and also peripheral features, and the other way around.
So to that point, I think it's important to keep in mind when you see patients that a patient may have peripheral disease, as you heard, but still have axial spondyloarthropathy or ankylosing spondylitis in the older terminology, and would be classified as such. Psoriatic arthritis, as one of its phenotypes, has axial disease. So it does get to be a little bit blurred. Also, as many of you may know, there are patients with inflammatory bowel disease who may present with axial disease or peripheral disease, and that too feeds into the confusion of making an accurate diagnosis, as we'll explore with you in just a moment.
Yeah, and where this becomes important is actually when you come to decisions about treatment, because it's becoming increasingly clear that arthritis in peripheral joints and axial disease don't respond to the same types of medications. So it is important to find out what are the predominant features in the individual patient so that the treatment then can be adjusted accordingly. So next slide. You have to push that. Yeah. So this is just something to show you, give you an idea about how frequent the spondyloarthritis diseases are. And so here you see that the green bar is higher than the blue bar for rheumatoid arthritis. So as a family, spondyloarthritis is actually quite common. Individual diseases may be much rarer, so reactive arthritis is probably not that common, but as a family, they are at least as common as rheumatoid arthritis. Now, ankylosing spondylitis is one of the spondyloarthritides. So it's characterized by inflammation in the axial skeleton, and that inflammation involves the SI joints, but also vertebral bodies, as well as posterior elements of the spine, so facet joints or other parts of the vertebral bodies. Prevalence estimates vary tremendously, and that has something to do with how these studies are done. And we already talked about this. There's overlap of ankylosing spondylitis with and involvement of the axial skeleton with other disease manifestations, peripheral joints or also extra-articular manifestations. And I think we have the first.
So we do.
question.
Let me just make one more point before we go on to this, and that is that another term that you may hear or see is the term seronegative spondyloarthropathy. And what that refers to is a patient who does not have a rheumatoid factor. The family of diseases that we're talking about are the seronegative spondyloarthropathies, of which ankylosing spondylitis or axial spondyloarthropathy is one, and psoriatic arthritis is another. Inflammatory bowel disease-related arthritis is another. But that gets you the overall picture of what we're dealing with in terms of classification of these patients. And finally, the last teaching point for your purposes should be to keep in mind that there are patients with rheumatoid arthritis who may also be seronegative, meaning that they don't have a rheumatoid factor or an anti-CCP, if that's what you're measuring in your panels or your labs. But seronegative rheumatoid arthritis is very different from seronegative spondyloarthropathy based on the clinical features of the disease, as we're going to be discussing. So we come up to our first audience response question, which we like to ask a few of these to gauge some background information, both of where everyone is and in terms of where we should be in our educational formulations. So first question. Which of these is a possible clinical manifestation seen in ankylosing spondylitis axial spondyloarthropathy? A, glomerulonephritis, B, uveitis, C, migraine headache, D, oral ulcer, E, I'm not really sure. Please pick one. A prize to anyone who can tell me what that clip of music is. Booker T and the MGs, very good. Okay, so here are the answers that we've gotten, and overwhelmingly, everyone seems to have recognized, 87% of the audience, that uveitis is a possible clinical manifestation. Migraine headaches, well, migraine headaches may occur in anyone. They're not unique or in as great frequency in ankylosing spondylitis, axial spondyloarthropathy. Glomerulonephritis, no, not really. I'm not sure. Fair enough, because that's why you're here, to learn about the condition. So, one other important factor is that disease occurs in genetically susceptible individuals who encounter an environmental trigger or triggers. And that is an overriding hypothesis to try and explain all rheumatic diseases. But in fact, if you think about it, for any of the diseases that you're interested in, even possibly the metabolic ones, it may be the result of an environmental interaction with an individual who has a particular genetic predisposition. Now, not everyone with the genetic background or the genetic susceptibility factor will develop the disease. And that may be because of the fact that they haven't encountered the environmental trigger or triggers. And not everyone who encounters the environmental trigger or triggers may develop the disease because they may not have the same or common genetic background that's predispositive. Now, when you do have the interaction between genetics and environment, and other factors superimposed or concurrent with them, such as the microbiome, which we're learning plays an important role in perpetuation of disease, if not initiation. That is the combination of factors, the perfect storm, that leads to the development of an autoimmune disease. For our purposes tonight, spondyloarthritis. And what you're hearing is that there are different clinical phenotypes, that individuals who encounter the same environmental trigger or triggers may nevertheless present in somewhat different fashions. And that adds to the complexity and that adds to the difficulty in the diagnosis as well as the characterization of these patients as they're seen over time. So you've heard the term genetics, and the genetic factor most at play is the allele of the HLA system, the human histocompatibility locus, B27. Jörg, why don't you tell us about it?
Yeah, so no discussion of axial spondyloarthritis or ankylosing spondylitis gets away without mentioning or discussing HLA-B27, and that's important from two perspectives. One is that it's the most important genetic factor in the disease, and it also plays a role in diagnosing patients. So it's HLA-B27 is an allelic variant of the HLA-B gene, and it encodes the heavy chain of the MHC class I complex. So if you remember the days of your immunology course, and MHC class I molecules are expressed on the surface of all cells in the body, and they present peptides, which can then be recognized by CD8 positive T cells to trigger immune responses against viruses or also against tumors. Now, why HLA-B27 is associated with ankylosing spondylitis is, to this point today, not clear. There are several hypotheses, but they're still being investigated. Now, I mentioned that the other reason that this is important is making a diagnosis. So when the association between axial spondyloarthritis, or at that time ankylosing spondylitis, and HLA-B27 was discovered in 1973, it was clear that this is a very strong association. So 90% or so of patients with AS are HLA-B27 positive. The other types of spondyloarthritis are associated with HLA-B27 to a lesser degree. In PSA, for instance, the estimates are between 40 and 50%. However, being HLA-B27 positive does not make a diagnosis. And the reason for this is that it's a variant that is frequent in the general population. So in the US population, overall, the frequency of HLA-B27 is 6.1%. It's slightly higher in whites and is lower in other ethnic groups, but still that's a substantial number. So indiscriminately interpreting HLA-B27 plus back pain equals ankylosing spondylitis would be wrong. So let's go to the next slide. And this slide talks about how difficult it is to make a diagnosis because there's a substantial delay between the onset of symptoms in patients and when the diagnosis of ankylosing spondylitis is made. And that gap that in this study was about 9 years is still persistent today. Now, what are the reasons why there's such a gap between onset of symptoms and a diagnosis? And there's a number of reasons. One of them is that the patients may not be take it that seriously or may not be aware, but also because their doctors and their care providers may not be aware that that chronic backache that the patient complains about is actually not just garden variety back pain, but is an expression of an inflammatory disease in the spine that needs to be treated more aggressively than with Tylenol, for instance.
Yeah, and I think just to amplify a little bit, there are also factors related to gender and cultural norms. For example, as you'll hear, this is largely a disease of younger men, and younger men who have a little bit of back pain may be not so quick to go and see their physician and may want to attribute it to any other causes. You wake up on Monday morning with back pain, well, okay, I played too much sports over the weekend. So you go through the rest of the week, and then you continue to have some back pain. You wake up the following week, well, I was out partying too much this weekend. And on it goes until when we see patients, we often find that they have more significant lesions in their spine and sacroiliac joints than they should because they're already grade 2 or grade 3 by that time. So we want to make the case for earlier thinking about inflammatory disease, but not so much so that anyone with a backache becomes a heightened individual for suspicion of ankylosing spondylitis. So that brings us to the first of a series of clips that you'll hear, because one of the things that we think is important is the communication between physicians and patients. And so what we've done is go out and ask a number of patients with ankylosing spondylitis to relate to us some issues concerning their disease, the diagnosis, and their therapy. And at this point, we'd just like to play a few clips so you have the patient's perspective in your mind.
I saw 7 physicians in my search to discover that I had ankylosing spondylitis. It took 7 physicians and 6 years.
I saw at minimum 15 to 20 doctors in the various parts of the country that I lived in over about a 13-year span.
Approximately 4 physicians and 20 years.
6 doctors. I went to 2 primary care physicians, 2 rheumatologists. I went to an emergency room physician, and then I finally went to an ophthalmologist. So I guess 7.
So there are a number of good questions coming in, and we're going to get to them in just a second when we finish this section of the module. But one of the things you've heard about is inflammatory back pain. And inflammatory back pain is a term of art that we in rheumatology use because we think it's very important for anyone seeing patients to be able to differentiate between mechanical disease, inflammatory disease, and widespread pain syndrome. Now, there may be overlaps that will make the problem even worse and the diagnosis even more subtle. There may be people with inflammatory disease who have some degree of mechanical dysfunction as well. But for the purposes of differentiating them, individuals with mechanical back pain tend to be older than individuals with inflammatory back pain. The onset of mechanical back pain tends to be acute, whereas for inflammatory, it's insidious. For people with mechanical disease, the end of the day is worse, and for people with inflammatory disease, the morning is worse. They will tell you that they are uncomfortable or stiff when they wake up. They may have some morning stiffness, which is uncommon in people who have mechanical disease. Nocturnal back pain, which is the inverse, if you will, of morning stiffness and morning pain, is worse for the patient with mechanical disease at the end of their day, and for individuals with inflammatory disease, it's worse in the middle of the night when their inflammatory pain has caused the musculoskeletal structures around the source to really gel, if you will, and solidify. Now, exercise makes pain worse for people with mechanical disease. Exercise for people with inflammatory disease, interestingly, makes the pain better because they're able to free themselves from the constriction of the inflammatory effect on the surrounding structures. NSAIDs are quite good for relieving pain in patients with inflammatory disease because NSAIDs are anti-inflammatory. People with mechanical disease may also have relief from the analgesic component of an anti-inflammatory, but to the extent that their pain is not as much inflammatory as mechanical, the relief of pain and the incidence of relief of pain may be less so. And finally, mechanical back pain may be associated with radiculopathy and sciatic symptoms, inflammatory back pain much less so. But less doesn't mean never, and so this differentiation is really meant as a generalization rather than anything specific. You've heard us use the term axial spondyloarthropathy, which is the newer term for ankylosing spondylitis, which is itself a newer term for Maurice Drumpel's disease or von Bechtereau's disease, which are some of the other eponymic terms that you'll see in the literature. We no longer like to use eponymic terms, but rather terms that describe the pathogenesis of the disease. Very recently, we have come to recognize that while patients with inflammatory spine disease generally are detected because of changes on their plain films, there are a proportion of patients who may not have changes on their plain films, but may have abnormalities on an MRI. So if you have a patient with inflammatory back pain who has negative back x-rays, and you have a suspicion for this being inflammatory and possibly one of the conditions we're talking about, that would be appropriate to push for an MRI to see if we're dealing with the entity of axial spondyloarthropathy, non-radiographic in origin or in etiology. When you have inflammatory back pain and the imaging studies are positive, well, then you can say you have the patient with radiographic axial spondyloarthropathy or radiographic AS, and those individuals will meet the criteria that we'll talk about in a moment, whether they're the modified New York criteria, which have been around about the time that I arrived in New York, or whether they are the newer Ankylosing Spondylitis Assessment Society score that have been developed in the last decade. Now, what you're getting from us, I hope, is a picture that there are objective signs and symptoms of systemic inflammation that can occur in multiple organs, that there are objective measures of systemic inflammation that we can assess the signs and symptoms with, and we can couple these with other factors such as a family history and whether or not the individual is positive for the gene HLA-B27 expressed on their white blood cells, that we can hone down on the diagnosis of ankylosing spondylitis. So there is no one thing that will make the diagnosis. B27 will not make the diagnosis. You need the constellation of symptoms to make the diagnosis, and the full range of symptoms are important so that you can define a timely diagnosis and appropriate management plan. Now, here you see both the apparent signs of inflammation and the hidden signs of inflammation that may be operative in patients with different forms or different phenotypes of this disease. Remember, I mentioned that patients with psoriatic arthritis may have an axial presentation, and patients with the axial presentation may or may not have skin disease present at the time of their presentation. Another great problem is that people may present with joint disease before their skin disease or skin disease before their joint disease, and that becomes an important area to continue to evaluate. Also, if you are dealing with the axial inflammation of skin disease, you may be dealing with a patient who may not be aware that they have skin involvement. They've attributed their flaky scalps to dandruff. They've attributed their dry skin to eczema. They may not be aware of the small patch around the umbilicus or in the gluteal cleft, which they can't see. Now, I've mentioned that there may be people with bowel disease who have a phenotype of axial spondyloarthropathy. And to further complicate matters, patients with idiopathic ankylosing spondylitis or axial spondyloarthropathy may have some gut inflammation that's unrelated to any specific GI complaints. With regard to the joints, you can be dealing with pure axial disease, where it makes it easier to recognize what you're dealing with, pure peripheral disease, which makes it a little bit easier, or mixed disease, because there may often be patients with one form who develop the other, or with the other form that develop the one. So we need to be aware that we may be dealing with distinct entities which are part of a family, and not to get so honed in on just one particular feature. As a famous professor once said, patients don't always read the textbook, although nowadays they're going online much more often than you can imagine, and perhaps they are. Okay, so before we get to the second learning objective, Jörg and I are going to address some of the questions that have come in the last several minutes. So first of all, do you require a special lab to do HLA testing? Jörg, what do you think?
It's a routine test. The way it is done varies. HLA-B27 is a genetic marker, but you can test that at the protein level. So there are the classical test is a cytotoxicity assay, which is probably way too detailed to explain that here. But in today's world, many labs do a PCR-based assay, so that is something done on DNA. But it doesn't require a special lab, so that should be part of any routine laboratory.
Can damage be reversed if there is no fusion? We may differ on this, but I have to tell you I'm not convinced that damage can be reversed whether there's fusion or not. One of the strategies that we try to employ is to get patients as early as possible to prevent damage from occurring. It's really difficult to assess whether damage can be reversed once fusion or erosions or calcifications have occurred. Jörg, what are your thoughts on that?
Yeah, so damage that has occurred cannot be reversed. So the goal really is to treat early. What we don't know yet is who will benefit most from aggressive treatment. So there's a big variability in how the disease phenotype in the individual patient evolves. Some patients very rapidly, for instance, form new bone, which is the hallmark of ankylosing spondylitis, which can then lead to initially syndesmophyte formation and then fusion of the whole spine with an, immobility and increased risk for fractures. But not everyone does that. And although we have a few ideas about risk factors for this, this is still an area of ongoing research.
If a patient comes in with sacroiliitis, should I consider AS? The answer is yes. If you think of it, it is probably something that's worth evaluating. There are other causes of sacroiliitis, but if you have a young individual with sacroiliitis complaining of what could be inflammatory back pain, and you get radiographs, then certainly it is something to think about. Is there a link between AS and PSA? If you have a patient with PSA, are they at risk for AS? They are two different nosologic entities, but what we're trying to get across is that there may be common features such that patients with psoriatic arthritis may present with axial disease, and some patients with axial disease may actually go on to develop some skin problems. Okay. Let's go on to our second learning objective. We will come back and answer as many questions as we can as they come in. So our second objective is to look at classification criteria and diagnostic testing, note the use of two different words, into our practice to support the early detection of this disease. And let's begin with the distinctions between the two. Jörg?
Yeah, so we don't have diagnostic criteria for spondyloarthritis or for any of the spondyloarthritis entities. And the ACR, or the committee of the American College of Rheumatology that deals with these things, recently published a paper which is cited here where they said, well, we are not going to work on diagnostic criteria anymore because to do this is actually very complicated to come up with something that is valid under all certain circumstances. So what we work with and what we have are classification criteria. They are very helpful. They can be helpful in making a diagnosis in the clinical setting. But you have to take the classification criteria.
Maybe you should use the mic again.
Yeah. You have to take the classification criteria with a grain of salt. It is possible to make a diagnosis even if a patient does not fulfill the classification criteria by the book. Nevertheless, it's important to know about them, and so let's do that. So, next slide. You saw earlier in one of the slides the two types of, or the two main criteria sets that we use. So for ankylosing spondylitis, we have the modified New York criteria from 1984. And a patient that fulfills these criteria is someone who has inflammatory back pain, someone who has limited range of motion in the thoracic spine or in the lumbar spine, and at the same time there is imaging evidence on X-ray of the sacroiliac joints. So that is also the first test, or one of the first tests that one should order in a patient where you suspect axial spondyloarthritis or ankylosing spondylitis. And the test to get is a simple AP pelvic view. There's no need for additional oblique views of the SI joints because X-rays of the pelvis are associated with a significant radiation dose. So a simple AP view is sufficient. And so according to these criteria, you need one of the clinical criteria plus significant imaging evidence for sacroiliitis, and then a patient can be classified as ankylosing spondylitis.
But remember, these are classification criteria. Making the diagnosis in an individual patient requires your overall assessment of that patient and not just reliance on population criteria, but individual specifics of that given person in front of you.
Yeah, and so these are the newer criteria for this broader category of axial spondyloarthritis. And the development of these criteria, and you heard about this already, was driven also by the need to identify patients earlier, to identify those patients that have not yet developed that full-blown picture of ankylosing spondylitis. So the Strictly speaking, these criteria only apply to younger patients that have back pain for at least 3 months. I think that's also useful in clinical practice, because it would be extremely uncommon for a patient with axial spondyloarthritis to present at age 65 with a history of back pain for a year. That is much more likely to be a patient who has mechanical back pain or some other etiology, but spondyloarthritis would be extremely unlikely. So according to these criteria, patients can be classified in 2 ways. Either they have evidence for inflammation in the sacroiliac joints, either by X-ray or, in this case, by MRI. And then they have one of these spondyloarthritis features that are listed in that box on the left. So having inflammatory back pain, having peripheral arthritis, enthesitis, uveitis would qualify in conjunction with chronic back pain and sacroiliitis for to be classified as having axial spondyloarthritis. If you look at the spondyloarthritis features, there are also a few other things of note. So it was already mentioned that spondyloarthritis generally responds very well to NSAIDs. So that is one of the criteria that can be used here. And important is also a family history of spondyloarthritis. Now, what are the diseases that we look at here? So it's not just axial spondyloarthritis, and probably if you ask a patient, do you have a family member with axial spondyloarthritis, they will say, what are you talking about? But psoriasis, psoriatic arthritis, inflammatory bowel disease are also part of the family. And so if you can ask about this, and if a patient or a suspected patient with axial spondyloarthritis has a family member with inflammatory bowel disease, that would count here. So the other way to classify someone with axial spondyloarthritis is the right arm, and that's also called the clinical arm. And here you need the patient to be positive for HLA-B27, plus 2 of these clinical features that we just talked about. And this arm, or this part of the criteria, is something that is really very controversial, and there has been a lot of criticism about this because it's not very specific. So it's actually relatively easy to fulfill if you just go by the numbers to fulfill these criteria. I mentioned that in the general population, HLA-B27 is present in 6.1%. So it's not that rare. And then all you need is a family member with psoriasis and a positive response to NSAIDs, and that would classify someone with axial spondyloarthritis, and the patient may not have the disease. I don't know whether you want to...
No, so there were 2 questions that we can answer in response to this slide. Somebody asked about the sensitivity and specificity of B27. It's a very difficult question to answer because it depends on the clinical features in that patient, and it also depends upon the gender and the ethnic background of that individual. So if an individual is from a population where there is a higher frequency of HLA-B27 in the general population, the sensitivity and specificity will be different than an individual with inflammatory pain who comes from an ethnic background where it is lower if they're B27 positive. If you have an individual who's B27 positive from an ethnic background where the incidence is low, but they have inflammatory features, you have to consider them as having ankylosing spondylitis. Someone else asked about a patient with sacroiliitis, whether they should be worked up. And I think what you see here is if they have clinical sacroiliitis and you confirm it radiographically, then yes, you probably should be working that patient up because they have met at least 2 criteria, whether one on the right and one on the left, but you have to evaluate for whether any of the other criteria may be present as well.
Yeah, I want to take the opportunity to answer another question. That was about the MRI. So how do you evaluate the sacroiliac joints by MRI? when you order an MRI of the lumbar spine, you often can see the upper part of the SI joints, but that's not sufficient for evaluation. So typically you have to order an MRI specifically of the SI joints. And then what we're looking for, the most specific sign for sacroiliitis is actually bone marrow edema. So it's not synovitis or fluid in the SI joints, it's also not erosions. What we're looking for is bone marrow edema, so inflammation in the bone underneath the SI joints. And so this can be done without giving gadolinium, without giving MRI contrast. So there are fluid-sensitive sequences that can be used, and the radiologists that actually do the studies, they should know about this. The most commonly used sequence is called STIR. That is the test that you need. You don't need to get an MRI with MRI contrast.
We've already covered part of this slide where I gave you the differentiation between non-radiographic and radiographic, but there are a couple of other points to make from it. Jörg, would you like to go into it, please?
Yeah, so this slide here has a bit of epidemiological information on it. So if we just look at the bottom right part of the slide, there you can see HLA-B27, 90%, male to female ratio 2 to 3 to 1. So this is what you've learned in medical school about ankylosing spondylitis. It's a predominantly male disease and very strongly associated with HLA-B27. Now, if you look at the other side, you see HLA-B27 positive about 60% and male to female ratio 1 to 1. So studies have shown that if you broaden the concept of the disease, all of a sudden you actually have also quite a few women that may have this or that have this. And it seems that actually male gender is what predisposes the bone formation, what makes people to move from non-radiographic disease to radiographic disease. But the inflammation in the spine that causes the inflammatory back pain and that causes the discomfort, that is as common in women as it is in men.
So what you're hearing from us is that perhaps as important in this condition, if not more so, is getting the thorough history. And the thorough history has to include some questioning about extra-articular features, about the nature of the complaint that they're having, about the temporal components of the complaints that they're having, about any family history of the complaints that they're having or any of the diseases we've discussed. Diagnostic testing of a suspect individual should include a measure, an acute phase reactant to define if there is inflammation present at that time. We've talked about the role of the genetic marker HLA-B27. We've talked about plain films as well as a more specific MRI if the plain films are negative. We've given you the clear point that even if an individual is positive, it doesn't make for B27, it doesn't make the diagnosis. And a negative B27 or a negative MRI of the sacroiliac joints do not rule out a diagnosis. There is still a significant role for clinical judgment in this particular area. But the more features that are present, the higher the likelihood that you are dealing with AS, whether you're calling it ankylosing spondylitis or axial spondyloarthropathy. Now, important for your considerations, and I think probably the major reason that you have interest in this and are here tonight, is that you want to know when should I refer the patient? What can I do myself? And when should I be referring the patient? Well, obviously, we have a very self-serving point of view, being rheumatologists. But patients with chronic back pain of at least 3 months, particularly if their back pain is occurring when they're younger, under 45 years of age, we think should be referred to the rheumatologist, particularly if one of the following parameters are present. If you think they have inflammatory back pain, as we've characterized it for you, with the different features between inflammatory and mechanical. If they're HLA-B27 positive. If you've imaged them and they have sacroiliitis on either the X-ray or the MRI. If they have peripheral manifestations. if they have extra-articular manifestations in the skin, in the bowel, in the eye, if they have a positive family history, if they have a good response to nonsteroidals. Now, a good response to nonsteroidals can be nonspecific. Lots of people can have a good response to nonsteroidals. But we're talking about a good response in this clinical setting. And obviously, if they have acute phase reactants that are elevated, which make the point for inflammation as a feature of what you're dealing with. If you have individuals with this constellation of symptoms, or any of these symptoms, then they should be referred sooner rather than later. And let me say something, because one of you did ask about difficulties in getting patients to rheumatologists in your clinical area. Nothing makes a rheumatologist happier than seeing a patient with inflammatory disease, because there's so much we can do for that patient. Nothing makes a rheumatologist sadder than seeing a patient with widespread pain syndromes, because there's not that much more that we can do than you can do. So if I'm in my office and I get a call from one of my referring colleagues saying, look, I have this young man here, he has eye inflammation, he has an uncle with ankylosing spondylitis, he's in here complaining of back pain, I'd like to get him seen, I'm likely to fit him in the next slot that I have, or fit him in the next opportunity that I get to see someone, because I know I don't want that patient to wait. On the other hand, if I get a call, I have an individual here who's seen 92 other doctors and no one can find out what's wrong with her, my general response is, I'm not going to be the 93rd, and my partner is not going to be the 94th. So if you have a patient with a high degree of suspicion for inflammatory disease, contact the rheumatologist directly. Don't go through the secretary who will just look at the book and say when the next opening is. I promise you that any rheumatologist worth her salt will want to see a patient with inflammatory disease sooner. A couple of pictures to keep in mind. We've been talking about radiographs. Tell us what's going on here.
Yeah, so this is an AP view of a pelvis, and this was done in a young woman who had developed low back pain about a year before she came to see the rheumatologist. She had a family history of psoriatic arthritis. Her father had this, and she actually was diagnosed with, or she had scalp psoriasis a few years before the development of the low back pain. And on this radiograph here, there is some very subtle evidence for sacroiliitis, in particular on the right side. So the right SI joint is what we see on the left. And there is some sclerosis and some irregularity in the inferior part of the SI joint, some erosive disease. So the findings in this particular patient here are pretty subtle. And she subsequently had an MRI, and that MRI was clearly positive for bone marrow edema, actually on both sides, worse on the right, but also on the other side. There were a few more questions that came in with regard to diagnostic testing, and maybe we can answer these. So one was about characteristic findings in the lumbar or thoracic spine. So the bone marrow edema lesions that I mentioned around the SI joints, you can find these also in vertebral bodies. Typically, they are at the corners of the vertebral bodies. They can also be in other parts of the spine. However, the yield is higher in the SI joint. So in a patient where you suspect that this is someone who has spondyloarthritis, the diagnostic focus should be on the SI joints, not on other parts of the axial skeleton. And that is one of those situations. I think that once you're at that level of suspicion and you're not sure, the best thing really is to refer that patient to the rheumatologist so that the appropriate tests can be ordered. A second question, maybe you can take that, it was about the CRP. What kind of CRP elevation would you expect in somebody with spondyloarthritis?
I think that's going to depend, the level of elevation of the CRP is going to depend on the degree of inflammation that's going on at that point in time. and whether or not the patient may have other etiologies to elevate the CRP as well. So patients with ankylosing spondylitis may have other conditions too. I was taught by a professor who said that if you have a patient with rheumatoid arthritis who has hemorrhoids, don't call it rheumatoid vasculitis. It's hemorrhoids. So if you have a patient with ankylosing spondylitis who has a urinary tract infection or a cellulitis unrelated to their disease, the CRP may be quite elevated because of the combination of their underlying inflammation and their acute inflammation from that second condition. So how elevated would I expect it? I would expect it to be elevated, but I would also want to be concerned that there are no artifacts or lowering of the CRP. But I would expect it to be elevated, but I'm not going to give you a specific number. It's really going to depend on the individual patient. So speaking of individual patients, let's hear a bit more from our patients at this point in time.
No, I did not feel like I had adequate understanding of the testing that was done. And I get the same feeling from my community that some doctors, whether they're primary care physicians or rheumatologists, kind of just throw out tests just to see what sticks.
My primary care physician did not do any tests. I was referred to an ophthalmologist because of my eye pain. The eye pain was triggering the doctor to look at the blood test HLA-B27 gene, which he then therefore ruled and diagnosed me that I have ankylosing spondylitis.
No, the possibility of me having arthritis or inflammatory arthritis was never addressed by my primary care physician. I had asked for several tests just trying to get an understanding of what was going on, if it was lupus or some other form of inflammatory arthritis, but I was never able to receive any of those tests. I was never referred to a rheumatologist. I was referred to orthopedic doctors a few times, but still I was not successful in being able to get a diagnosis or testing by a rheumatologist until I sought out one on my own.
So what I take away from this is that there is a great deal of difficulty and dissatisfaction because patients often aren't diagnosed, particularly if they present with extra-articular manifestations. It's much easier when the patient presents in the classical fashion than when they present in the atypical fashion. Sir William Osler once said, "You'll never be fooled by what you don't know. You'll never be fooled by an uncommon illness. You'll either know it or you won't. You'll be fooled by a common illness presenting in an uncommon fashion." So we'll be fooled by an individual who's presenting with eye pain because we may not see them first. We'll be fooled by other individuals presenting atypically, and I think what you're hearing is the dissatisfaction of the patients in that particular setting. There's one thing here I would like to address quickly. There's a question about, is there any relationship between diet and ankylosing spondylitis? In a word, no. We don't know of any foods that cause the disease. We don't know of any foods that make the disease better. We are learning, as I mentioned, about the role of the microbiome, but we can't yet say that a particular change in the microbiome either augments the susceptibility to or the clinical presentation of or the clinical course of. But as far as treatment effect goes, I again come back to what my professor taught me, which is when all else fails, find out what the patient likes to eat and forbid it. So that's the only comment I'll make about diet. Okay, we're ready for another audience response to gauge your perspective. Which of the following should be considered first-line therapy for AS? A, indomethacin. B, methotrexate. C, etanercept. D, secukinumab. E, I'm not sure.
Coming in out of the rain, they hear the jazz go down.
It's not coming up on the pad. Okay, it's now.
But the horns, they blowing that sound.
That was a ruse to get some more music playing. Where's my musicologist? Who can tell me what that is? Right. Sultans of Swing. Mark Knopfler, great guitarist. Okay, which of the following should be considered first-line therapy? Well, you heard us speak about non-steroidals as the first-line therapy. Maybe that's what the unsatisfied patient was talking about by oldest and cheapest, or maybe that's coming up and I'm just having a senior moment. But 2/3 of you correctly recognized indomethacin. Methotrexate as first-line therapy, maybe you're thinking that what to do after the non-steroidals that the patient has taken over the counter has failed. Etanercept, for appropriate biologic, but the criteria that we'll talk about in a moment suggest that there are things that can be done before going to a biologic. Secukinumab, which we'll also talk about in a moment, an appropriate and approved biologic. And a couple of you honestly said, I'm not sure, and until you hear about the therapeutic choices, that may very well be an appropriate answer. So let's go forward. Okay, now let's look about the therapies that we have available and how we're going to use them in clinical practice. So here are the recommendations. Take us through them.
Yeah, so this is actually a slide that's about 10 years old, but the major ideas that are on this slide are still valid with some modifications. What we want to focus on is axial involvement, and the medications that are used for axial disease are just a few. So non-steroidals are the first-line treatment for axial spondyloarthritis or ankylosing spondylitis. And if that fails, then we go to biologics, namely TNF inhibitors, because they've been approved for this indication for a number of years. More recently, the secukinumab as the first IL-17A inhibitor has become available, but is at this point considered a sort of third-line treatment after non-steroidals, TNF inhibitors, but that may change at some point in the future. What's missing here is other drugs that you know from other rheumatic diseases, such as sulfasalazine. We can go back maybe to that slide before. Are other drugs that we know from other rheumatic diseases, such as methotrexate, leflunomide, azathioprine. So there's no role for these in the treatment of the axial manifestations in spondyloarthritis. Sulfasalazine is on this slide, and that is on here because that is something that you can use if the patient at the same time has also peripheral disease. But we don't use any of these older DMARDs for treating axial manifestations. In addition to these drugs, important part of the management of patients is education and exercise. And so this slide here reviews again that NSAIDs are first-line treatment in combination with physical therapy. If NSAIDs fail, we use a TNF inhibitor, and if that fails, we can switch to an alternative TNF inhibitor or to an IL-17A antagonist. It's on this slide, so there is no evidence that any of the non-steroidals works better than any other. So the important aspect is to give a full dose. So naproxen 500 milligrams twice a day, or ibuprofen, 600 to 800 milligrams 3 times a day would be something that one should first try before declaring the patient a failure of NSAID therapy. And the same is true also for the TNF inhibitors. So although there have been no head-to-head comparisons, if you compare the studies, they seem to be equally effective. But in certain circumstances, there are some preferences. So we know, for instance, that etanercept is not effective in patients with Crohn's disease or in patients that have uveitis. And so this is a slide about physical therapy. So that is something that is often neglected because we tend to focus on drug therapy, but it is important. Interestingly, studies have shown that the best type of physical therapy is inpatient spa exercise, which might be difficult to get for most of our patients. But any type of physical activity ultimately is better than no type of exercise. And so what are the exercises that people should do? So patients who have ankylosing spondylitis, in particular if there's any evidence for very stiff, bony stiffening of the spine, for syndesmophyte formation, the important thing is that they do regularly range of motion exercises, deep breathing exercises to maintain the degree of mobility that they have. The situation is somewhat different in patients on the other end of the spectrum that have non-radiographic axial spondyloarthritis. So these patients should be physically active just like everyone else. Patients with ankylosing spondylitis, so again, these are the patients that have the bony stiffening, they should not engage in contact and other risk sports because of the increased risk for fractures. But they should do the more subtle range of motion exercises.
Okay, last opportunity to hear from our patients to again bring everything together from the point of view of another stakeholder in the process.
Neither of them explained to me the process or the prognosis of the disease or how it affects people on or off medicine or things that I could do to slow the progression on my own without medicine. I felt very much alone. And I think a lot of people in my community, online and Facebook groups of 20,000 members, feel the same.
No, it was not explained to me. However, I have done a fair amount of research online and talking to other healthcare professionals. I am aware of what drives my treatment, but it wasn't clearly explained.
I was not necessarily told about stopping radiographic progression, only that I needed to start on the oldest and cheapest form of treatment until we found one that had success. And that did cause a year of medications that did not work and or I had severe reactions to before being able to be started on a biologic.
I think that's the clip I was thinking of, the patient who was probably rotated on non-steroidals before getting appropriately to a remittive agent in this condition. So what to do after non-steroidals? You've already heard that we tend to go to the biologics when we can, if in the absence of any contraindication. And we have now 6 biologic agents available for use in patients with AS. We have 5 TNF inhibitors. They differ in terms of route of administration and frequency of administration. But as you've heard, and as you'll see, there probably isn't a significant difference in terms of their effectiveness in a population of patients. Are there differences in individual patients? There very well may be. We have all experienced situations where Mrs. A is not doing well on drug A, but doing well on drug B, and Mrs. B is not doing well on drug B, but doing well on drug A. You can have 2 patients in your examining rooms on the same drug, one swearing by it and one swearing at it. So you really can't predict what's going to be appropriate in a class for any individual necessarily until you've tried it. We wish we had better predictors, but within a class, that's really difficult. And now we have the newest agent, secukinumab, which works by a different mechanism, inhibiting another cytokine, interleukin-17A, and we'll look at some of the data for all of these. None of these have been studied in a head-to-head trial. So the first thing to keep in mind is whenever you're making comparisons like this, if they're not in a head-to-head trial, they are at best qualitative rather than precise. Because it's not unless you study things head-to-head in the same population, with the same statistical methodology, with the same inclusion-exclusion criteria, that you can really make comparisons. That said, we do it all the time. And here it is on this slide, where we're looking at the pivotal trials for 5 of the TNF inhibitors at their approved dose versus placebo, and what you're seeing is that they are all achieving about a 58, 59, 60% effectiveness in terms of a 20% response in the global assessment score, which we use in defining an appropriate response in a clinical trial and a distinction from placebo. And here is secukinumab. Secukinumab is the only IL-17A inhibitor that we have available. And it too has differentiated itself from placebo at different doses. And you can see out here not just a 20% improvement, but a 40% improvement, and not just a short-term improvement, but a durable improvement out over a year versus placebo. And we even have more recent data that was presented at our last American College of Rheumatology meeting, looking at the durability of secukinumab now out over 3 years in significant patients who have been in the trials and then the open-label extensions of this interleukin-17A antagonist over time, and the dramatic response that we're seeing and keeping in them. So keep your eye on this. Okay, time for another question. We're getting near the end of our presentations, and then we'll take many more of the questions that have come in. But while we're at it, we've talked about B27. How often should B27 testing be done? Monthly? Whenever therapy is changed? Annually? Never? I'm not sure. Oh dear, oh dear, oh dear. The correct answer is never. It's a genetic marker. It doesn't ever change. There is never a rationale for measuring the B27 again in anyone, whether they have disease or not, once it's been measured once. It is not going to change. So we don't look at it when we change therapy. We don't look at it annually. We don't look at it ever after we've looked at it the first time. In the first portion of the program, we've talked about when to look at it, and so we never look at it again once we've had. But when we treat patients, there are other things that we're concerned about. Jörg?
Yeah, I just want to make another comment about the repeat HLA-B27 testing, because that also brings up this question of what are things that we can actually do to monitor therapy. Because the title of today's evening is about precision medicine. And so there's a lot of discussion about treat-to-target strategies and precision medicine in rheumatic diseases, including the spondyloarthritis. That is something that is evolving. So right now what we use are 2 tools that largely rely on patients' responses to certain answers. So one is called the BASDAI, the other one is called the ASDAS. So these are validated disease activity scores. The BASDAI measures the answer of the patient to 6 questions about disease manifestations, back pain, morning stiffness, duration, morning stiffness severity. And the ASDAS also includes a few patient questions, and in addition, the CRP value. So these are tools that the rheumatologists use to measure disease activity. What we don't know yet, and that the future will show, that whether adjusting treatment based on these activity measurements will actually result in improved outcomes long term. And so that is, as I said, ongoing research. But what we already need to do is to make sure that the patients that are on the biologics to treat their disease are safe. And so the 3 things that we want to look out for are on this slide. So first of all, infections. So you know about the TNF inhibitors that are associated with an increased risk for infections. and also with a risk for TB reactivation. Similarly, to the TNF inhibitors, if we use other biologics, we screen patients for this. And because of that, there's no evidence at this point that, for instance, IL-17A inhibitors result in TB reactivation. But the studies essentially excluded those patients where this could be seen. One potential side effect that is more specific for IL-17A inhibitors or other drugs in that pathway, you may have heard about the IL-23, IL-17A axis, is mucocutaneous candidiasis. That is a potential side effect that is not seen in TNF inhibitors. It's typically very responsive to oral or topical treatment, and the biologic does not need to be, treatment with the biologic does not need to be interrupted. The other thing that we look for is malignancy, but that really is, we are looking for non-melanoma skin cancer. That's probably the most important one in the TNF inhibitors. And then the other thing is fracture. So in patients that have ankylosing spondylitis that are doing fairly well, all of a sudden they come in, things have changed, they have much more back pain. So the two things to consider is one, maybe they have an infection in their spine because of the biologic, or two, maybe they have a fracture because of the stiffened spine that is very prone to fracturing. And it's also in these patients we see osteoporosis, which contributes to an increased fracture risk. So if there's a change in symptoms, consider infection and fracture.
So someone asked an interesting question. Why do you give these biologic medications very difficult big names? And the serious answer is that all of the names that they're given have a particular rationale that is consistent with a naming convention, international naming convention. For example, the suffix CEPT means it's against a receptor. The suffix MAB means it's a monoclonal antibody. So if you recognize what the suffix is, that tells you the structure of the molecule, and then you're just left with Inflixa. You're left with Etana. You're left with adalimumab. So that's not so long and difficult once you realize what the suffix is and that it connotes the molecule itself. We've talked about diet. We've talked about other kinds of adjunctive things. Should we be checking vitamin D and doing a bone scan in our patients with ankylosing spondylitis who are or are not on therapies?
So the management recommendations of the ACR, the Spondylitis Association of America, and Spartan that were published a couple of years ago, they actually recommend doing bone scans. The problem is that we don't really know what to do about it.
Right. Well, there is some data to suggest that the TNFs may allow bone density, if not to decline, to remain stable longer. And based on that observation, we're now doing a large-scale study at Hospital for Special Surgery looking at patients who are on secukinumab to see what the treatment, the effective treatment with secukinumab does to maintaining bone health. We don't have the answer yet. We've just enrolled our first patient. But we think that biologic therapy may actually improve bone health. But if there are other reasons for putting a patient on calcium and vitamin D, a postmenopausal woman, for example, we should certainly take counsel from our endocrinologist. A patient on corticosteroids who may be at risk for glucocorticoid-induced osteoporosis. Those are special situations in those categories of patients that may mandate a different kind of intake. We felt this was particularly important because more often than not, it's going to be the patient, the physician who referred the patient to me and to Jörg that's going to be handling their immunizations annually, seasonally, and what have you. So the first point we need to make and establish clearly is that if a patient is on one of these long-named biologics, they should not get a live vaccine. Period. End of sentence. If they are coming up for their flu vaccine, there are inactivated forms of the flu vaccine that can be given. And some of these are listed based on the 2017 Advisory Committee of the Center for Disease Control. And so the key thing for you is no live vaccines, attenuated vaccines as recommended, consistent with the CDC or your local infectious disease expert. So we're coming down towards the end, and we want to leave you with some practical points in terms of, hopefully now, your ability to recognize the key features of this disease that will help you in making an earlier diagnosis, or at least an earlier suspicion that will lead to a referral that will make the timely diagnosis. We'd like to see you incorporating the classification criteria and, where appropriate, the diagnostic tests that we've used to support the early detection of ankylosing spondylitis. Yes, it is okay to start a patient on nonsteroidals, as you've heard, while waiting to get the patient to the rheumatologist. One of you asked a question about how long should patients be on nonsteroidals. There are problems with chronic use of nonsteroidals. The FDA is going to be meeting next Tuesday and Wednesday to look at, more specifically, the cardiovascular complications of long-term nonsteroidal use with certain agents in the class versus others. So the only answer I can give you is the shorter period of time, the better, with the key understanding that this is a lifetime disease, but the newer therapies with biologics, which deal with the cause of the disease, may obviate or lessen the need for nonspecific therapies which deal with the effect of the disease. And if you have any suspicion of inflammatory disease, if you have any suspicion of axial SpA, AS, please get the patient to the rheumatologist. Please make the call yourself. Please, I promise you that that patient will be seen sooner by that rheumatologist if it's clear that your index of suspicion is of inflammatory disease, which we can do something about. And then together with the rheumatologist, you're going to co-manage the patient to reinforce the goals of therapy as well as monitor for the adverse events. It's flu season. You're on call. You're getting 99 calls on Saturday morning, and they all begin the same way. I have a low-grade fever. I'm achy. I have a runny nose. I have muscle aches. And 99 times out of 100, your answer is appropriate as fluids, acetaminophen, bed rest, monitor your temperature, call on Monday morning if there's no change. And then you hear from the one patient who gives you the litany of complaints and says, and I'm on etanercept, and I'm on adalimumab. Maybe that's the patient that needs to meet you in the ER or come to your office to be evaluated to be certain that that patient isn't cooking, if you will, an opportunistic infection or even a garden variety infection because of their higher susceptibility from being on the drug. So it's been our job to talk, and it's been your job to listen. We sincerely hope that not many of you got done with your job before we got done with ours. Thank you very much. And now we'll be happy to take the questions that have come in that we haven't already answered. Okay? I'll give it over to my colleague to begin and select his favorite questions.
Yeah, so here is one question is about corticosteroids, and we haven't really talked about those. There is no role for systemic corticosteroids in treating axial spondyloarthritis or ankylosing spondylitis. So that's different also from patients that have rheumatoid arthritis, for instance, or maybe peripheral spondyloarthritis. There is really no evidence that 10 or 20 milligrams of prednisone will help patients with inflammatory back pain. Corticosteroids are used in patients that have sacroiliitis locally with an injection, so there are circumstances where that is useful, but we don't use it we don't use corticosteroids as a systemic therapy.
What's your perspective on the use of patient-reported outcomes measures to measure disease activity in ankylosing spondylitis?
Very important. I mean, essentially, the tools that I mentioned earlier are largely patient-reported outcomes except for the CRP. And somebody asked here I should spell these. So the BASDAI is BASDAI, the Bath Ankylosing Spondylitis Disease Activity Index, and the other one is called the ASDAS, ASDAS.
PROs, though, are not as readily standardizable in ankylosing spondylitis as they have been in rheumatoid arthritis. We don't really have a good health assessment questionnaire that's standardized and reproducible in this condition that we're talking about today as for others, but patient-reported outcomes are critical. In all of our diseases, there are three things we look for: improvement in signs and symptoms, improvement in patient-reported outcomes, and, where we can get it, inhibition of structural disease. How do you define remission in ankylosing spondylitis?
Well, remission I would define as the absence of symptoms of disease activity. So that would be absence of pain and stiffness. And that's also I think without remembering the exact wording, the definition that the recent panel on treated target strategies in spondyloarthritis used. That does not mean, and it's more difficult to assess what's actually happening locally at the level of the SI joints or the level of the spine. There were a few questions about this. So, do the drugs that we use do they actually have an impact on structural progression? You want to comment on this?
Well, I think we've already suggested that once damage occurs, it's very difficult to assess reversal. But with that in mind, we always hope we're getting it, but that's also going to be a factor of the degree of inflammation and the metabolic bone health of that patient. So we don't look for regression as much as we look for inhibition of progression. Here's an interesting question. If we're not able to stop the progression of the disease, what is the role of a biological? What is your take on cost effectiveness of biologicals over non-steroidals? So when I use the word cost effective, it means, is it worth the money? Now, we can measure the money. How do we measure the worth? I mean, how do we do the value? The first thing I would say is that non-steroidals do not treat the disease. They treat the symptoms of the disease. The biologicals treat the processes that are causing the disease. So to the extent that we are able to treat the disease rather than the effect of the disease, and to the effect that our patients have significantly improved quality of life from a biologic as compared to a non-steroidal, I think that that justifies, at least in my mind as a prescriber, the use of a biologic agent. It may not to the payer, who would much prefer to see us using leeches, which are natural and don't cost them anything, or perhaps cupping and coughing, but I think we can make an effective argument for how these biologic therapies have really improved quality of life and thus have become cost effective. Your thoughts?
Yeah, I think that there is quite a few patients whose symptoms are sufficiently controlled with non-steroidals, and from that perspective, I think it is also a reasonable strategy, as the treatment recommendations are, to first start with non-steroidals and assess the response. Now the question, and as I said, the treatment should be with a full dose. Like naproxen 500 milligrams twice a day or an alternative non-steroidal. The question, is it safer for a patient to take this lifelong versus switching to a biologic drug? and what happens with regard to structural damage, i.e. new bone formation in the spine and the potential for spinal fusion and a fracture down the line. I think these are open questions that we don't have an answer for at this point.
Someone asked, are there any medical benefits from regular massage therapy? I assume the questioner means in the patient. There have been studies done looking at chest wall massage to try and increase the chest restriction that is seen in some patients with axial spondyloarthropathy. Those studies have been inconsistent. Massage may induce a sense of well-being in some patients and may make them feel better, but I'm not aware of any randomized control trials establishing or justifying the use of massage therapy as a primary therapy as opposed to adjunctive. York?
Yeah, I agree.
Okay.
There were a few questions here also about how long should patients be treated, both with regard treatment with non-steroidals or treatment with biologics, and what happens if you stop therapy. Do you want to comment on this?
Well, this is an exploring area. We are just looking at what it means to taper or discontinue therapy in patients who are on it. These are lifelong chronic diseases. These are diseases that we do not cure. These are diseases that we treat, hopefully to remission, and then when patients are in remission, we face the question, what do we do next? And there are studies looking at tapering strategies. There are studies looking at discontinuation strategies. Here's the problem, and I'm speaking about all of our diseases, not just one. If you taper or discontinue, some patients, and we can't predict who, some patients will do quite well, thank you very much. But some patients will flare their disease. We can't predict who. And so if we take those patients who flare their disease, we can put them back on their therapy. And some of those patients will recapture their stability. Some of them will not. We don't know. We can't predict who should be stopped, who should be tapered, who should be discontinued, who should be spaced out. We don't have the data on that yet, and these trials are in progress. Any associations with AS and other autoimmune diseases like Graves' disease? Not so much, really. We've tried to give you the spectrum of articular and extra-articular conditions within the family of the seronegatives conditions and the axial SpA. Other autoimmune diseases, like Graves', tend to have a different genetic predisposition. Now, I'm sure there are patients who inherit the predisposition to both, and there may be patients with both conditions. But that doesn't mean that one is a feature of the other. These may be two independent pieces of bad luck.
Yeah, so this is actually also a very interesting question from a scientific perspective. So we started out by talking about the overlap between the different spondyloarthritis family members at the clinical overlap that you see, and also the overlap with regard to family history. And over the last 10 years, as you know, many genome-wide association studies have been done that essentially looked at these things unbiased. And these studies have shown that the same SNPs, largely, the same SNPs come up in the spondyloarthritis family diseases. So inflammatory bowel disease, psoriasis, psoriatic arthritis, ankylosing spondylitis, they've been studied, and they share many of the risk genes. Whereas rheumatoid arthritis, lupus, other types of autoimmune inflammatory diseases have different risk genes. And so I think that's part of the answer to the last question. So the genetic risk is really for certain types of diseases that are part of the spondyloarthritis family.
Do nonsteroidals slow the progression? No. These are purely treating symptoms. They have not been shown to have any disease modification, any significant disease modification, if any. There may be some older studies looking at their effect on some of the earlier measures of disease activity, but they have not been shown in studies in controlled trials to slow the progression of the disease.
Yeah, I would actually be a bit more open on this with my answer on this question, because there are some studies that have shown, and a lot of preclinical data actually suggest a role for prostaglandins in bone formation. But the more recent results are very controversial. So the best evidence that we have is 2 clinical trials that were done, one 10 years ago and one a couple of years ago, that used a similar design where they compared patients that were put on nonsteroidals on a very strict schedule, so they had to take it every day, and the others were asked to just use it as needed, and the patients were randomized to the 2 arms. The study 10 years ago showed that the patient that took the nonsteroidals on a regular basis had less radiographic progression over 2 years. The study that was done 2 years ago showed the opposite. So right now, there's really no evidence for a disease-modifying activity of nonsteroidals, although I would say there might be.
So last comment, there are a couple of questions on comorbid complications, cardiovascular risk, and malignancy risk. I think the general comment we'll leave you with is that or undertreated inflammation is a major risk factor for cardiovascular disease and malignancy, not necessarily in the same person, but or undertreated inflammation are the 2 biggest risk factors for those 2 comorbidities. And what we're trying to do is get patients treated earlier, more appropriately, with the agents that we have so that we don't have to deal with the sequelae of or undertreated inflammation. Well, our time is up. We want to thank you for a lot of interesting questions that have made us think, and hopefully you found this program enjoyable, educational, and informative. Thank you very much.